Hey everybody, I'm Dr. Roney. Welcome. It's been a while actually since I've been on here with y'all, so I wanted to say hello. If you are new to the cancer conversation, I want to welcome you. If you've been a consistent watcher, I want to welcome you back. I know I see a lot of you in the clinic, and even the new patients that come in, they tell me all the time how much they enjoy the class, and I appreciate that feedback. As you know, I mean, I'm a big fan of information. I'm a big fan of the more you understand a plan, the more you understand the details of the plan. I think it really just helps you breathe easier mentally, right? This is enough of a shock to some people and overwhelming, especially when they first come here. So I think understanding it, the plan that is much better, I just think it helps you kind of breathe, let the shoulders relax, and then just allow the healing to happen. So the only way that can be done is through information and through teaching. So I love doing this. You all know, if you've been on this, that this is one of my favorite times of the week. So appreciate you being on, and again, hope these help you significantly. So tonight it's a Q&A. Dr. Ptak and I will be on the entire time. I'll do my intro as I always like to do, because there's new people that come on each week, and I want to make sure they understand. I guess unbiased to the clinic is what I always say. I want to make sure you understand the plan that I've seen personally work really well, that I recommend to anybody that calls me out of town. I'm from back east. I have friends and family call, hey, this person was diagnosed, what would you recommend? And I give them the plan. And so I'll go over that with you. I know if you've been on before, you've heard me say it numerous times, but if you're new, I think it's important that you understand that if you do have a new diagnosis and or you have a family or friend who's been diagnosed, that you can at least articulate this vision to them and a plan that we see work extremely well if the I's are dotted and T's are crossed. So I want to make sure I do that for you. I'll also introduce, we're doing from a wellness standpoint and pre-cancer wellness prevention. If somebody, pre-heart disease, some of these major chronic diseases that we're seeing, we've come up with a structured plan, wellness plan, that people can come to the clinic. They can get a very structured set of visits and tests and modalities done, all on the precipice of prevention. So I'm going to mention that. We'll go through my intro, we'll go through the questions, and at the end I'll highlight what that wellness plan looks like, because we get that call all the time, like, hey, I want to prevent. What tests do I do? What treatments do I do? So we came up with a very good plan for that. So we're rolling that out, and I'll review that. So anyway, I want to take the opportunity to go through briefly at least the 4 pillars that we look at, okay? And I'll share the screen because these pillars are on the screen, and I just want to make sure that, again, if you're new, that we could take you through step by step. So let me pull that up, work you through the 4 pillars, then I'll go back a little bit and we'll go over some things. So, okay, number 1, what we want to make sure we're doing when we test is we want to make sure that we're not only doing the scans, like your PET scans and MRIs and CAT scans and ultrasounds and things like that. We also want to make sure we take a deeper dive into some of the tissue biopsies or the liquid biopsies. There's testing like the RGCC test, the Garden 360 test, Fulgent test, the Datar test. The list goes on and on. There's a lot of tests now that we could do to gain a significant amount of valuable data that could help with the circulating tumor cell test, kind of dial in the chemo agents. If somebody had to do, say, low dose chemo here, we dial in the agents. We can find clinical trials with some of these tests for the patients. So we definitely have a lot of tools in the toolbox that we can now use within that liquid biopsy or tissue biopsy testing heading. And then, of course, our blood work, the CBCs and the CMPs, complete metabolic panel, complete blood counts, and our iron and ferritin and our homocysteines and vitamin Ds and our hormone panels and our blood sugars and insulin and CRP, which is a C-reactive protein, is an inflammatory. I mean, all those are relevant in addition to your tumor markers, like for breast 15-3, 27-29, your CA125, your CEAs, your 19-9s, for males, the PSA, prosthetic, the PSA, the antigens for prostate, and so forth. So again, between the tissue or liquid biopsies, the blood levels, your tumor markers, we can get into great detail on painting a picture as to what is going on in the body, as well as how serious it is, what staging it is, as far, not necessarily stage, you need a pathology report for that, but to just give you an idea more and more of what's going on and the severity of it. So that testing is important to take a deeper dive so we can treat you more as an individual as opposed to cookie cutter. And then, of course, here we get into some energy testing like bioimmune testing. We get into the Mead testing, which tells the voltage of the cell. We do live blood cell analysis. And the one thing I try to explain to patients all the time is that blood and urine, for example, can pick up things, at a certain level. Scans, it tends to have more of a change to pick up a change on a scan, but energy can pick it up very early in the process. So anytime there's changes in cellular energy that's reflected in some of these scans or tests that we do, you can pick up things much earlier than you could with blood or urine or even scans like CAT scan or PET scan and so forth. So here, the beauty is Dr. Keneally is really constantly trying to get different tests and different levels of testing because we don't want to miss anything. It's really about maximizing your upside, dotting I's, crossing T's, things like that. So pillar one is the comprehensive testing, plus a lot of the energy testing and all of it, so we get a good picture painted as to what direction we need to go with you as the individual in your care. The second pillar is the starve phase and the kill phase of cancer, right? So starving would be using repurposed drugs like metformin, antiparasitic meds, some statin medications, some antibiotics, things like that. Those are all designed to help kind of disrupt or block certain pathways that feed the cancer cell, which is why we term it the starve phase. That's not 100% accurate, but just for purposes of explanation, that's kind of how that works. It gets a little more involved in that. And then we have the kill phase. So the kill phase of cancer is going to be things like, in the conventional world, chemo, surgery, radiation, immunotherapy. Here, a lot of people come to us because we do low dose chemo. We use insulin, use the insulin, bring down the blood sugar, and then we infuse the chemo agents found by, say, the Garden 360 test that's more individualized, that then can, because the glucose is down, can almost target the cancer cells with leaving a lot of the surrounding cells alone. And that works really well. And because we do that, or meaning we bring the blood sugar down and we can target those cells, they can use less percentage of chemo agents. So it's sometimes 10%, 20% of the normal dose is used. So there's less side effects, less nausea, hair loss, things like that, neuropathy. We tend not to see those. So that pillar two is starving the cancer using the repurposed drugs and a form of a kill phase. What I try to explain to patients is what we use, or what we would even recommend, is dependent upon what's on the paper, the objective quantification of your medical records, scans and blood work and things like that. Sometimes, unfortunately, there's just a little bit more ammunition needed. I'll say, hey, sometimes the bomb or the atomic bomb is needed, as long as it's done in conjunction with all the other things that I'm about to explain. I personally have seen people do really, really well, and I'll kind of summarize that in a second. So that's pillar 2. Pillar 3 is going to be things like immune boosting. It's going to be things like oxygenating, alkalizing, increasing the voltage of the cell, testing the nutrition of the cell, and then working to basically reverse that environment. So we want to use oxygen. We want to use things that alkalize the cell and the surrounding blood and plasma. We want to make sure that we do voltage increasing with the MEAD or the biomodulator or biocharger, things like that. And that becomes really important because the hallmarks of cancer are what? Low oxygen, high acidity, low immune function. So we want to change that environment very quickly. And a lot of the supporting therapies we have and we do either test for that and then treat those things in pillar 3. So that becomes really, really important, especially when you first get here. We want to change that environment. And then pillar 4 includes causes, right? So I always say in the conventional model, and not good or bad, because I think there's definite relevance as to sometimes a very strong need for the conventional model. But it's one chapter, I would say, of a 20-chapter book. And so these other 19 chapters are critical. And one of the chapters left out that's significant when somebody is treated for cancer in the conventional model are the causes, right? How did this happen in the first place? What's going on in the body that created this environment for damaged cells to replicate? And they're, looking at, when we look at pillar 4, we're looking at things like infections, whether they're viral or bacteria, or fungal infections like candida and or mycotoxins from mold infection. We're looking at heavy metals and non-metal toxins and different toxins in the body, right? We're looking at these things that are foreign, right, in the body that the immune system is going to have to react to, which creates that inflammatory response, creates the free radicals, the oxidative stress to the cell. I mean, I'm simplifying it, but that's where the causes come in. And then how about if there's blood sugar dysregulation and thyroid malfunction and anemia and different other metabolic conditions going on in the body that also create, and I didn't mention stress, which is one of the top ones, right? That also create, an environment that's conducive for growth. So we want to look at all of it. And combined, if we do the right testing, we starve, we kill, we oxygenate, alkalize, immune boost, increase the voltage of the cell, help the nutrition level of the cell, and then clear out a lot of the junk, if you will, the gasoline to the fire, we basically have increased the upside significantly, and we mitigated the downside. So that's the 4-pillar approach that we take, and we're big on making sure that we're dotting every I and crossing every T in each of those pillars, which again just simply maximizes your upside significantly. So that's our 4-pillar approach to cancer. That's my intro. I wanted to do that especially as it relates to the questions, because a lot of the questions say, hey, what can I do for this cancer or that cancer? And so I wanted to touch on that briefly and say the 4 pillars is what you want to do generally overall. What will change is what we do in that pillar number 2, which is the kill phase. Does it need chemo or surgery or radiation, or can it use low-dose chemo, immunotherapies? Or for some people, none at all apply. Maybe they've had a lot of chemo before. Maybe they've had a lot of those therapies before, and they're not able to do them again. Well, then they're out, and then we use a lot of these adjunctive modalities, high dose vitamin C and artisanates and things like that, hyperthermia, to create a cytotoxic effect in the cell. So it could be a combination of everything. It could be some patients, can't utilize those. It really depends. But specific cancers, right, we're going to use the 4 pillars, but then we're going to get specific on what exactly, that kill phase looks like. And we'll talk about that as we go through the questioning. So without further ado, Dr. Ptak has arrived. So I'm going to introduce her. And then what I'll do is go back and we'll go from the beginning and kind of give us a quick intro. Y'all, I've been on here plenty, so I'll let Dr. Ptak give her a quick
intro about myself?
Yeah, okay. Absolutely.
All right, hi everyone. I'm Dr. Roney Ptak. I'm a licensed naturopathic doctor. I graduated from Bastyr University in Southern California, and I actually started here in my 4th year of medical school as a student, shadowing, and I got to work really closely with Dr. Keneally, so that was great. And then I started here soon after that. Before that, I was at Princeton University, and I studied molecular biology there. So
I was going to make sure she threw that in, but go ahead. Yes, that's impressive, by the way.
And I also played volleyball, and I feel like athletics made a big impact on, my role on the team here, and my interest in medicine and how the body functions and how to optimize health. So agree.
Sports is always I think a great, I don't know, it's just a biggie for me personally too. Okay, so we talked about, I already gave you the 4 pillars. So for those of you that are new, we're in Irvine, California. It's a 30,000 square foot facility. Half is designated to more of a wellness, half is designated the Cancer Center for Healing for cancer. Probably from a tool standpoint, I guess we have as many tools as most clinics, as far as what I understand. I think we also have some of the top doctors in the integrative oncology world, along with doctors like Dr. Ptak, myself, Dr. Carlton, Dr. Rowe. I mean, we just have a really good number of solid clinicians working on this every day, and very eager to learn too. That's what I think is the curiosity part. I think is a big deal too. You just go through this world of healthcare, and you see a lot of doctors that just they become rocks. I'll call it, where they feel like they've got it. They don't need to know more. But I think if you're a sponge, you just continually learn, and you're curious, and I think all of our doctors are. Would you agree?
Mm-hmm.
Yeah, I think that's what makes us really good. So, okay, I did want to mention this because I mentioned it right before the 4 pillars. But one of the things that we get requests on consistently is this wellness plan. A patient that calls us and says, hey, what do I do for cancer prevention? What do I do for heart disease prevention? I have some chronic disease, diabetes, or what have you, that runs in my family. What can we do? Well, we put together this day 1, day 2, day 3, and follow-up care for patients that want to come in and take advantage of the center and do a lot of I would call it a structured program for wellness and optimizing your health. And so what you see here, and I'm going to go over this at the end because it'll make more sense, but you have a visit, and then you have the assessment and what we would do day 1, and then you would have a follow-up to go over the blood work, and then at day 2, and then we would have remote follow-up consults involved with that, and that there's a fee for that and a package fee for that if somebody so wanted it. And again, the reason we put this together, we would get those calls all the time, so we figured we'd put it all together in a nice package. I will review that at the end. I just want to mention it at first. The other thing too, we're working on changing a little bit of the cancer conversation, I think, structure. What I'd like to do in the new year is create a syllabus along with the help with a lot of the doctors, and almost teach it like a course, right? So when we go to, if you've ever been to, whether it's high school or college course, the first day they give you a syllabus, and the syllabus, and I didn't love the syllabus back then. It was like, day 1 syllabus, right? Then I really realized that was I should have listened a lot more. It was the roadmap, exactly. So the point I'll make is that in the new year, I want to create a syllabus, and I want to create a week-to-week schedule that flows, right? That we're going to look at, maybe going through the 4 pillars and everything cancer, I call it. So everything from cancer treatment, prevention, optimal health, optimal wellness, diagnosis, you name it. I want to make that course throughout the year that flows almost chapter to chapter. So it's much easier to follow, I think. That's the one thing with a syllabus, that if we have a step-by-step guide as to what we're doing and where we are, then it flows like chapters in a book. That's what we're working on now. So we'll give you more insight into that as time goes on. Okay, so we went over the 4 pillars. Dr. Ptak, do you have anything before we answer questions? Anything big? Anything exciting? I know we're always talking, and there's always it's challenging. We're always kind of working through things, but at the same time, there's a lot of wins that happen. And we had. I was talking to a patient today. The husband came in, and it's a patient of yours, Kuma. So the husband came in. What she's doing, both in the conventional model and then here, she's doing really, really well. So the scans are coming back extremely positive. They feel like they're going to do another scan, I believe, on the 16th, and they think it's going to be pretty much gone. And then he's asking, okay, what are the next steps? Real excited, So those are things that you get day to day, and it makes you smile.
Yeah, I can think of another woman I've been working with kind of since almost the beginning of the year. Her case is interesting to highlight based on some of the questions that you all sent in preparation for today's call, the question of diagnosis and detection. And she was someone that was dealing with a lot of chronic symptoms for a long time, and it wasn't until finally they ordered a CT scan and saw that there was lymphoma. And so by the time she got here, we strongly suspected lymphoma, but she hadn't gotten a diagnosis, so we got her in right away with the oncologist. She was able to start chemo. She went with the dose-dense chemo model.
So we referred her out.
And we were able to get her diagnosed very, very quickly, like within a week or two. And we went with the dose-dense model for her kind of cancer.
Which is a full dose conventional.
A follicular lymphoma. And she's been doing the chemo once a month since then, and she just had a clear scan.
Awesome.
So
and she's doing
all the supportive stuff here, and she feels like her ability to tolerate the chemo was, greatly improved by being here, and we have all the support for side effects that can come up. And so, she's very pleased, and we're gonna obviously continue care with her because a clear scan doesn't automatically mean the chapter's closed. It's kind of the beginning of the story, actually.
Great point. And that's one thing, we see with Dr. Devlin, who does a really good job as a consultant here. But one of the things that I've seen from Dr. Devlin as an example is when there's no evidence of disease, he's still keeping them on a protocol for low-dose chemo maybe every 3 weeks. And he's still having them do all the adjunctive care. And he says it might be a year or two of doing this until he feels super comfortable, and surveillance. So we have a very good surveillance protocol, 6 weeks of these labs, a month of maybe every couple months of this scan or these scans. And that's a repetitive thing. That way, if something does pop up, along with the tissue biopsies or the liquid biopsies and such, and being able to put all those labs together, scans together, to make sure we are clean. And that's a really good thing. And I'll highlight some family member. This is a good kind of parallel. So she had a lumpectomy and then radiation about 2 years ago. Everything was clean after that. So the margins were clean. We did circulating tumor cell tests. Those were clean.
So this patient started here at the time of her diagnosis?
Correct. And then her follow-up, so scans are good, everything's good, but the follow-up CTC test showed some circulating tumor cells. So it was 0 after surgery and after the radiation, and then it popped up that they were like 2.3 or so. So it's like, okay, is something brewing? Well, with that, we then did all the tumor markers. So your CA15-3 was breast, 27-29, but we also did your 19-9s, which is more for ovarian, and
pancreas
and 125 ovarian. And we did the CEAs, and we did a number of tests that way. They all came back clean. And then we did the Gallery test, which we'll talk a little bit about. That can look at roughly 50 different cancers, early detection, right? And that came back clean. We're waiting on the Signatera test. She did an MRI, clean. So the point I'll make is when something like that comes up, it just sparks us to then go, okay, maybe we need to take the deepest dive we can. And so far, everything's coming up clean. So now we're not 100% sure exactly what's what, but we know nothing really is brewing. But we will work on bringing those circulating tumor cells down and maybe do a SOT treatment or something like that. But the point I'll make is that's where, if it's a catch-22 is a little bit, because when we take the deeper dive, things can come up, and it could worry patients.
Well, I've been saying that a lot more recently as we expand our ability to test circulating tumor cells and circulating tumor DNA and the tumor markers. I always tell patients the benefit is early detection if it's going to happen, and the downside is the anxiety of having that test done every 1 to 3 to 6 months, depending on what cadence you're on. And so I do have some patients decline it ultimately, and that's totally your prerogative.
Yeah, agree. So now with all the extra testing that was done, it's pretty clear that things are good, right? But some work to do just on the adjunctive, like we're going to do more oxygen therapies and more immune boosting and so forth. Point I'll make is though, in today's world, this is what I think, and I think you might echo this, is that we're just seeing stuff that, and as clinicians, when you see it consistently, I personally want to be on the early end of it than anything. So I'm personally okay with doing those tests. And this person was actually same thing. She's like, oh no, I'm really good. I know it created a little bit of anxiety, but I'm really good that we did it. So now I'm totally sure things are good. So anyway, but it does create a little dichotomy of a little bit extra anxiety there, but it's worth it. Okay, let's jump in. You ready?
Yeah.
Okay, so colon cancer, this is the first question. Colon cancer runs in my family. I just had a colonoscopy and had polyps that were removed. What can I change in my diet, supplements, etc. to help not getting additional polyps?
Well, I mean, if it comes down to colorectal cancer risk in general, some of the main things are just age. You can't really avoid that.
Right.
We have to be eating enough fiber in a day. Fiber provides nutrients for our microbiome, and so we have more balanced immune system and mucosa there. But it also acts as a binder, so it can actually pull toxins out.
Correct.
The bulk of it tonifies the lining of the colon. And so you're getting, it's kind of a weird way to think about it, but just in the same way that you need to exercise your arm muscles and your body muscles to keep those muscles strong, your colon muscles have to be exercised. So having bulk there for the colon to process actually tonifies it if you're hydrated enough. Risk factors that we want to avoid are smoking, of course. There's going to be a connection with parasites as well. Anything that's causing inflammation and agitation at the colon lining is essentially a signal that the body has to kill something, detox something, heal the tissue, and a polyp is basically an overgrowth of tissue. Sometimes it's disorganized. That's what makes it look suspicious and why it has to be removed, because it's compounded disorganization that leads to issues. So additionally, we actually need digestive rest. So we think about fasting. It's when we fast and, rest, like sleep, that our body can go into repair mode. And instead of creating disorganized healing and leading to polyps and weird overgrowths of tissues, it can actually repair and clean up damaged DNA and create a more organized healing pathway. So fasting looks a little bit different for everyone. Men in particular do well with intermittent fasting. It's like a daily thing of 12 to sometimes 18 hours of fasting. I think it's a little harder on women, especially menstruating women, because it can be a burden on the cortisol system, and so hormones can be affected. But the research shows that intermittent fasting of 12 hours, you get profound benefits. And that looks like not eating from 7 p.m. to 7 a.m. So the issue comes in when people are late night snacking. And then sometimes we recommend doing a 3-day fast once or twice a year. There's fasting mimicking diets where your body still operates its metabolism as if it's fasting. If you're eating up to 500 or 800 calories a day. So there's ways of doing it if low blood sugar is an issue for you, that's kind of mimicking the benefits. So we have to think about colon rest as well. Good point. Yeah, I just kind of went on a deep dive there.
Yeah, no, it's good. Yeah, and I like, the colon, if you separate the upper, middle, and lower digestive system, the lower digestive system is that colon. The upper digestive, upper 2/3 would be your stomach, right? The upper, and then your small intestine. So I'm a big fan of we talked, Dr. Ptak mentioned this, but what you put in is going to be significant, right? So anti-inflammatory diets are probably the best, one of the better things you can do. If you're putting clean fuel in your body, and I like to use the term, just eat real food, That's a big part of it, right?
Did it come from the farm or the ocean or the lake or whatever?
Exactly. I use the term, if you can't pick it or chase it, right? Now, I know the idea of meats and things like that as it relates to colon cancer. We all know that connection. What I think, if we have colorectal cancer or colon cancer, and you wanted to shift to a more plant-based diet, I don't think anybody would have a problem with that, right? You're going to get more fiber, as you mentioned. You're going to get less of probably TGF-1, which are the growth factors, potentially from the meats.
And insulin growth factor.
Etc. Having said that, if you're not privy to that and you want to still eat meat, I do think getting your farm or pasture-raised, pasture-finished meats are going to be a much more benefit to you, and you keep it clean. I think if you eat your healthy organic fats, whether it's the nuts and seeds or you're doing avocados or your good oils, I think that's a big part of it. And then keeping your carb conscious, your vegetables, some fruits, some low glycemic fruits, mixing in maybe a complex carb with say sweet potato or something like that that's really healthy, nutrition dense, fiber as well, I think is a good plan in general, right? So it's eat real food and structure it with your fat, protein, somewhat dominant with a lower carbohydrate mix in there, right? That's clean. That's what goes in clean, gets into your stomach. I think good. You might like acid and or digestive enzymes, just to make sure that we're breaking those foods down properly, that when they get from the stomach into the small intestine, there's a couple good benefits of that. One, they're less inflammatory if they're broken down, especially proteins, if they're broken down properly. And then the second one is they actually absorb better through the gut wall and assimilate into the cell better. So food broken down properly, good food, and then broken down properly, has a big impact on the distal third. So if it's good and it's broken down and your microbiome is good and so forth, then I think what's going on in the colon is going to be much better. Now, again, to Dr. Ptak's point, the colon also has to be, looked at as well, and plenty of water is a big factor. Making sure you're moving your bowels properly, making sure you're detoxing properly.
We should be going to the restroom at least once a day.
At least, right? At least. They'll tell you, hey, eat poop, but that's probably a little aggressive.
Yeah, we can strive.
Yeah, we can strive, right? Exactly. But again, and I think too, not to get too into this, but I think full evacuations are big as well. So
does it feel complete?
Exactly, and we all know that difference where you're like or that was good, And I don't mean that. I'm being totally. There's full evacuation. If you're getting that, that's going to help as well, because you're not leaving junk in the colon to create, as Dr. Ptak said, that inflammatory response.
Or to recirculate the bad stuff that your colon's trying to get rid of.
Yeah, exactly. So I think, let's see, did we get all that? I think we got a lot of that. Yeah, that's a biggie. Okay, so we'll move on. So CML, so this says I was diagnosed with CML in 2008, and the CML has been held in remission with Gleevec. What supplements, diet changes would you recommend to ensure the ML stays in remission?
Well, I'd say before we talk about what can we take to keep suppressing cancer cells and keep cancer cells in dormant state, it's what are the root causes. And so when we think about blood and lymph and bone marrow related cancers, we're thinking, my mind initially goes to heavy metals, and then also to environmental chemicals, a lot of plastics, things that you'd find on a toxin pollutant panel. And so have those things been looked at? Because remission is a great time to really dive deeper into the root cause stuff. It's really hard when someone's got active disease that we're trying to target, and then we're also trying to detox. A lot of those protocols are contradicting.
Yeah, right.
And so I would say doing a heavy metal test. When we talk about heavy metal testing, there's a lot of argument over the best kinds of testing. I think everyone would agree, though, that what's just in your blood or in your urine on a regular day is not going to be an accurate reflection of your total body burden. Right. So
and the immune response. Yeah. Right, because that has to basically attach to the protein that creates the antibody, and then if you have an antibody response to it, which that's why I love Cyrex. They do a really good test with your chemical and your pathogenic. That's Cyrex 11 and 12, I believe. That shows the antibody reaction too. So we can get into that. But go ahead. Sorry.
Yeah, that's right. So the kind of gold standard is to do a provoked heavy metal test, where you either take orally or get an infusion of EDTA or DMSA or some other chelating substance that will flush the metals out of the tissues that they're hiding in, typically fat tissue or bone marrow. And then there will be a dump into the kidneys. It'll come out in the urine. You have to be careful, though, if you've got any active metal in your teeth or a joint replacement, the EDTA will pull metal out of those places. And so some people choose to do a provoked metal test if they've got active metal just to see what the burden is, but really that might be stirring up more trouble. So they have got hair samples. You can see the metals have been integrated into your hair over time. We've been doing oligo scans, and we've seen that to be helpful and correlating with patients' clinical history, and sometimes we'll confirm it with a provoked metal test. So that's it for the metal testing. There's all sorts of ways to eliminate them from, and we will have to be careful if there's active disease, but glutathione is helpful in a pulsed way, binders, actually replacing minerals that compete with the heavy metals can help eliminate them.
Oligoscan does a good job of looking at that, right?
Yeah, and then of course more EDTA and DMSA and the chelators. Alpha lipoic acid's helpful, cilantro, chlorella, all sorts of things. So that's good metals. As far as toxin testing goes and eliminating those, every toxin's a little different. We're thinking plastics, we're thinking of rocket fuel, we're thinking of stuff that ends up in your water that you've never heard of before, that just unfortunately can get there. So minimizing exposure by having good water filters, having enough electrolytes for the enzyme processes to detox them, liver support.
What you're putting on your skin and your hair and things like that are always a good way to start as well.
Yeah, we need to make a good handout for this.
Yeah, no question.
Every time we talk about it with patients, it's like
there's
a
long
whole
list.
Can of worms.
It is.
And wearing your shoes inside. Like, think about you walking through the parking lot, picking up whatever's on your shoe and bringing it into your home, and now you're sitting on your carpet or something like that. And the carpet can be problematic.
I know.
So, looking at the root causes. And then as far as, treatments to keep applying pressure on remission for leukemias and lymphomas, some of the classics just work the best. So the high dose IV vitamin C, repurposed drugs for a couple years can be helpful. I mean, this was from 2008. So the longer you go without a recurrence, the lower the likelihood of the recurrence happening. So that's really good. Probably don't have to be as aggressive. And then ozone can be helpful too. I've actually heard some good stuff, and I was thinking about implementing it more from some of my colleagues outside of the clinic who are doing a lot of UBIs for CML. So
ultraviolet blood irradiation works really well.
So this is where some blood is removed and ozonated, and then it's run through a light. There's UV rays that are part of it, but not the UV rays like the sun has that can cause radiation damage. This is the safe UV light that's actually kind of cleansing. So the ozone is activated by the UV, and it can kill circulating tumor cells and that. So
yeah, good treatment. Yeah, and I had a patient as an example to I guess parallel your point. This patient was in remission for the most part with CML. Numbers looked great. Had some type of infection, and then the numbers went bananas. So with that, to that point is, if your immune system is well regulated and strong, and you don't have a lot of gasoline, being poured on the fire, then your immune system is pretty calm and what they would use the term regulated and able to handle a potential load. But the likelihood, and he was just kind of working with us getting through some of the protocols that we have, and then this infection hit, and then things went bananas. But he wasn't quite there yet as far as getting rid of the burden and the load. So because there was a burden and a load, the immune system was already a bit revved up, and then it just poured more gasoline on the fire, and the CML went kind of bonkos. So the point I'll make is, though, to parallel your point, is that cause versus effect. You really have to delve into what the research shows as to the causes. And then for here, like we mentioned in the fourth pillar, there's kind of a laundry list that we look at, and we just start checking things off step by step.
Starting with the things that your history would tell us
Absolutely.
might be more relevant.
That's exactly right. So and great point, because people ask all the time, well, where do we start? Well, history plays a big factor. If somebody grew up on a farm, with a lot of pesticides and things like that, of course that would be a place that we start. And that happens quite a bit.
Or what happens is, since our patients here become a family, everyone's spending a lot of time together, people are like, why don't I have that test?
Yeah, that happens as well too. So yeah, CML, as well as any cancer, to be honest with you, but, and this is where we get into specifics, where research shows that this cancer can be fueled a lot by the heavy metals and toxins and so forth. So most likely that's a place that we would start. But again, getting rid of the fuels to the fire or the causes is key to this one and most of them. Cool? Good
Great.
with that? Okay, so what are the most promising developments in early detection methods for breast cancer, and how are they improving patient outcomes? Good question.
Yeah, I think Dr. Keneally and I kind of touched on this at the last Q&A, but I want to keep spreading the good news. There's so much development being done in circulating tumor cell and circulating tumor DNA testing, and while these tests are available to us, it's still the beginning of this technology and this capability. So we're still in the fog a little bit about the best test and the frequency and the accuracy, but
the number of tests
and the power of getting multiple tests all saying the same thing, we can do that.
Yeah.
And so some of the early detection methods that are helpful include the circulating tumor DNA testing and circulating tumor cell testing. So currently there isn't an available circulating tumor DNA test that I know of that's available for early detection. It's more for disease monitoring after a diagnosis, treatment, and monitoring for recurrence. Although I was speaking with a researcher at City of Hope a couple months ago who was talking possibly about a clinical trial there where they're doing ctDNA testing for early detection for pan tumor. And what some of the data is showing is that their preliminary data is showing that it's more effective possibly for pancreatic and bladder and a couple other cancers, which I guess the benefit to that being that we don't have good screens for those types of cancers, that we don't have a mammogram for your pancreas.
Right.
So having these tests, that test be possibly more accurate for those less screened for cancers, there's a lot of power in that. And then CTC testing, we've been using RGCC for years, and we're thinking about this other test that can add more power to our understanding of what's going on, the DATAR test.
The DATAR test, yeah.
So essentially what they're doing is looking for cells in circulation that have cancer features to them, that have markers on the surface that could be an indication of where they're coming from. And so one of the challenges with CTC testing to look for any cancer in the body is that every cancer origin is going to have a slightly different molecular profile and a different type of circulating tumor cell. So if they're looking for 100 different kinds of cancers in a 20 milliliter vial of blood, they can't be as sensitive. So you can add accuracy to the test if you have some kind of indication or some area that you want to look at.
A specific cancer, like, hey, this came out.
Maybe you have a breast nodule or a cyst, and you want to confirm if that could be cancer or not. The accuracy of that kind of test can go up if you tell the lab we're suspicious of breast, because they can dedicate more of that sample that they've taken from you to testing for breast.
Yeah, this is the family member I talked about, this is kind of what we were doing. We went down the road of, starting with a blank slate, if you will, and we paint a picture. And the picture is developed by looking at the tumor markers, right? Looking at D-dimer and nagalase and PHI, looking at MRIs, and I want you to mention the QT. Yeah, this is a great one.
Well, it's a new type of ultrasound technology that they have. Typically, when you get an ultrasound of the breast, which everyone with dense breasts should do because mammograms can't see through dense tissue very well, ultrasound is indicated, and you should put that as part of your screening. Or we'd be happy to order it for you if you want to come see us. The ultrasound, typically when you go, they apply the gel that the ultrasound waves are conducted through, and then the sound waves bounce off of the tissue and refract this pattern back, and the radiologist can interpret texture changes that indicate lumps and bumps and cysts pretty well, although ultrasound doesn't see calcifications very well. So the QT ultrasound, which we're still learning about, but there's going to be some locations opening up. I think one in Los Angeles opening up in August. They do an ultrasound where actually you're laying chest down and the breasts are submerged in a pool of water, and the sound waves travel through the water. So there's less kind of user error, I suppose, with the ultrasound head being moved along the breast tissue. And it's very sensitive. It can pick up on smaller detail of things. So
resolution-wise, what is it? Did I read?
I don't remember the
40
number.
times?
I don't remember the number, but very powerful.
Yeah, and less invasive. So it might be what I read.
Picture.
Yeah, it might be one of the go-tos moving forward for advanced early detection, which is great, right? And then I mentioned the Gallery test. That is a early detection test with, I believe, close to maybe an 90%. I think I read, I'm not 100% sure, but that's a test that we ran on a family member that came back negative. So nowadays there are a good number of things, and there's more coming out almost every day for this early detection. So I think they're starting to do a really good job with this, to be honest with you. So.
And then there's thermography, which is a very classic type of screen. Thermography is very controversial, basically, because, well, it's not diagnostic, but it's a helpful screen. So essentially, they're taking a picture of the vascularity in the breast tissue, and they're taking a picture of the heat patterns. So with the idea being that if there's a hypermetabolic spot somewhere, it's going to have more heat because metabolism's usually hotter, and it'll have more vascularity.
Correct.
The
and
reason,
it will read.
Yeah. So other things can cause increased vascularity and heat, like tissue injury related to exercise, or stagnant lymphatic can either look hot or cold on the imaging. Hormone imbalances, nutrient deficiencies like iodine. So all of those things, if that's the reason why the thermography is normal, that doesn't automatically mean that there's cancer there. So other imaging is needed to go with it. But those imbalances can set up an environment where cancer can grow. So because inflammation and stagnant lymph and hormone imbalances and nutrient deficiencies, that's like the perfect environment.
Exactly. And yeah, the thermography, I personally think it's great. But again, it's one tool in the toolbox that's used in conjunction to paint that picture. So if we say you had one a year ago, and you're doing them every year or 6 months if you have dense or fibrous cystic breast or something like that, and there's some changes that are starting to show, well, then you could go down the next step because it's very low invasive, right? Very non-invasive. So then we could do some testing, and if that's starting to show some things, then we can go to the next step with ultrasound or the QT, or we could do MRI, or we could order, I should say, any of those things along with the lab work. But I do think it's a good tool in the toolbox for sure. So glad you mentioned that because it is low invasive too. So, all right. Good with that one?
Yeah.
Okay, so what is the role of genetic mutations such as BRCA1, BRCA2 in breast cancer risk, and how are they being targeted in prevention and treatment?
So this ties into a farther down question that I'm going to bring up now, which is what percentage of cancer is caused by genetics. And it's true that only about 5 to 6% of cancers have that root cause of congenital genetic issues. That aside, it's aging. Every time your cell turns over, 9 billion base pairs have to replicate. And on average, there's 3 errors. So over your lifetime, as your cells continue to replicate, those errors can happen in areas of your DNA that are more important for healthy cell function and regulated growth and programmed cell death. But if it's happening in a part of the genome I don't think there's anything that's not doing anything.
Right.
There's a lot of the genome that's not doing some things that are very important. It's not going to be very consequential.
Yeah.
And so having as healthy as possible DNA replication is a huge priority. That requires a healthy immune system, enough nutrients, enough protein to make the enzymes that repair the DNA, having healthy telomere lengths, which is it's not very little, actually. It's quite a long piece at the end of DNA that gets cut off slowly every time the cell divides. So having healthy amounts of telomeres means that the edges of your DNA are protected. So aging makes up, 30 or 40% of cancer risk. And then there's the environmental and the lifestyle and the dietary and everything else.
Which could create the advanced aging, right? So those telomeres that you were talking about get shorter and shorter as we have more, I hate to keep being redundant, but more fuel to the fire. So if we have more of these infections and toxins and chemicals and stress and all that, and we're not handling it well, or it's manifesting, then those telomeres are going to get shorter and shorter quicker, which then those cells could become more affected, especially if there is a gene mutation. So there's a saying that DNA is not your destiny, right? Genes, the terminology is genes load the gun, lifestyle pulls the trigger, right? So, and I think that's actually relevant, and I think that's accurate in the sense that we could have these gene mutations, but it doesn't automatically mean we're going to get cancer. Is that fair?
Yeah, this is making me think of another patient I'm working with right now who, super healthy. We were shocked that she ended up getting diagnosed with a breast lump. She came to me with her diagnosis, and we came up with the plan together of what she was going to do to treat it. But she exercised daily. She ate really well. She had a pretty clean medical history and environmental exposure history. The tumor was kind of right here at the top outer part of her breast. And the only thing we could find, and I thought it was very significant after learning, is that she's got a couple of young toddlers. And as she's wrangling them and carrying the bags and groceries and her day to day, she keeps her phone in her bra strap. And having the radiation from the phone right there. And then on a deeper dive, we found out she was BRCA positive. So having that BRCA predisposition, and then we had the environmental exposure with the EMFs in a continued way for several years. That was the loaded gun and the trigger. But when it comes to BRCA, there's a couple different kinds of genes. BRCA is a tumor suppressor gene, which means that it's meant to help regulate healthy DNA cell replication. So a tumor suppressor gene encodes a protein or an enzyme that's role is to shut down overgrowth or overproliferation of cells. So if there's a mutation in a gene that's supposed to suppress a tumor, the suppression gets blocked. That checkpoint's not there, and so it has the potential to overgrow. And then on the flip side, there's something called oncogene, which is a gene that would normally signal a cell to grow and move into the replication and divide phase. Sometimes those get mutated in a way that they get chronically turned on. So we get the inhibitors turned off and the stimulators turned on. And that's where the genetic risk factors for cancer come from, is the genes that are involved in those kinds of pathways.
And those could be tested as well. These are some what they call epigenetic factors and genetic factors and so forth. So there is testing that can be done. We could look at those pathways. We can clean them up a little bit It's a great book, Dirty Genes by Dr.
Mm-hmm.
Lynch, that I think is a really good read, because these epigenetic or genetic factors, again, get turned on, if you will, by different stressors and lifestyle events and traumas and, of course, the fuels to the fire and so forth. So, but they also can be kind of turned down a little bit by cleaning some of this up.
Yeah, and to clarify, you're referring to the epigenetic ones.
Right.
And what he's referencing is genes that encode enzymes, which are proteins that are responsible for our detox and our hormone balance and the things that are related to cancer risk. These enzymes are responsible for modulating and working with. So it's more of the risk component versus the BRCA, the tumor suppressors, and the oncogenes. These you inherit, and they're related directly to, is the cell replicating or not, and how frequently, how often. And so because they're genes and not enzymes, there's less capacity to modulate them.
Correct.
Because with an enzyme, you can feed it, give it the precursors, you can give it the minerals and vitamins it needs to break down that toxin or process that hormone, make it work a little bit better. But a gene, you have it or you don't.
You have it or you don't. Yeah.
Yeah.
And again, it could be less affected or more affected by just lifestyle in general. And that's where it gets back to, even if you have those genes, it's looking at all the different factors that could influence those genes. And then if we're cleaner, if we have a healthier lifestyle in general, all over across the board, then those genes play less of a factor. Fair.
Yeah. And BRCA is not the only tumor suppressors. There's a whole bunch of other checkpoints. So as long as everything's clean, it can get caught or, prevented.
All right, good.
Yes.
All right. What are the key differences in treatment approaches for different types of leukemia, and how do they impact patient outcomes?
I don't know that it's specifically related to the leukemia, unless there's a really strongly associated environmental toxin or metal or parasite or something that's related to its pathophysiology.
The treatments are pretty similar.
Yeah, I'm actually thinking of another patient we had this year who had an eosinophilic leukemia. That
potentially from parasites.
Well, with his parasite treatment, the leukemia markers were improving a lot. So there's it depends on your risk and what caused that leukemia. But I'm thinking more about the age-related differences between what kinds of leukemias we see. A chronic leukemia versus an acute one, which happens in younger people. Things in younger people in general, cancers tend to be a little faster and more aggressive. On the flip side, younger people generally tolerate treatments better and can handle more aggressive treatment. So you don't lose very much in that sense. But I think it comes down as far as what kind of leukemia, maybe how aggressive we are, because there's different risk associated.
Yeah, I think I agree. I think it's one of those things where looking at everything collectively as to, okay, what do we need to do to treat it? Whatever that looks like in in our 4 pillar, the pillar 2, the kill phase, which again, in something like leukemia, a lot of times the meds are going to be effective, right? They're generally effective. So that is one aspect of it, that we might have to use the conventional or low dose or something like that. And then, okay, let's continue to do all the things that we talk about in the other pillars, especially the cause part of it, to try to eliminate those so those cells are healthier, they replicate better, all that. So I don't think it's specific. I think it's a little more general, as far as the treatment anyway, but it just follows that 4 pillar well. Okay, so can we develop more effective and targeted therapies for pancreatic cancer, which is known for its aggressive nature and limited treatment options?
Part of what makes pancreatic cancer so tricky, well, there's several variables. One, like we mentioned before, there isn't a regular screen for it. And that's why we've been big proponents of, you've got an abdominal symptom, we're doing an ultrasound, or we're doing a whole body MRI, and let's just get a baseline and see if we can see anything. the location of the pancreas being so deep makes it difficult to reach things from the outside. So when we're thinking about, and then there's a lot of collateral.
Mm-hmm.
The pancreas has your bile duct going through it, your aorta and the arteries going to and from your spleen and to and from your kidneys go right behind it and are kind of their branches coming off around the pancreas, and so it's pretty and then your small intestine.
It's definitely immersed.
Your small intestine wraps around the head of it. The liver's right there. So it's really limited in our ability to, not my ability, I'm not a surgeon,
sure.
for it to be cut out or to be radiated or to be, reached. Because I'm thinking like photodynamic therapy, the deepest penetrating laser is infrared, and that can only go 6 to 9 centimeters depending on how powerful the infrared is, and depending on your waist circumference, it's just hard to reach.
Yeah.
And there's the collateral issues. Because of all of the neighboring anatomy and vital organs, what ends up making it so dangerous is if the tumor or tumors obstruct the bile duct or obstruct the blood flow, or those are the things that can happen that can make it very quickly deadly. Versus, and it's not that one, I don't like to compare cancer types, but with something like breast, it's not on a vital organ,
right?
There's and it's not gonna, it's kind of out there. You can treat it.
You can access it
more easily.
Much easier.
The number one thing with pancreatic is early detection.
Definitely.
That's definitely a priority. Targeted therapies, if by targeted therapy you mean like immunotherapy or smart drug, I mean, they're coming out with a new drug every 6 weeks.
Right.
It's just which ones make it into the mainstream treatment, and we're always trying to build our referral network. We don't have any oncologists here at the center, and so we're to a certain level limited in our ability to get more creative and outside of the box with treatments, but we're always looking to
affiliates.
Find affiliates, and it really takes a village when it comes to these more specialized treatments.
One is going right into the tumor, right? Potentially.
Yeah, we've been looking at intratumoral injections of immunotherapy and making referrals for that. Immunotherapies, so they're different than chemotherapies. Chemo finds any cell in the body that's dividing and kills it. That's why we get so much collateral damage in our healthy cells, which are dividing. And that's why fasting can be so helpful around chemotherapy, because you put your healthy cells into hibernation temporarily. If they're not dividing, the chemo drug's not going to touch them. Whereas in immunotherapy, there's different mechanisms, but what it's doing is telling your immune system, hey, this is cancer, you should do something about it. And so like one of the most famous ones, Keytruda or pembrolizumab, what that's doing, it's an antibody. So when an immune system cell and a cancer cell come into contact with each other, there's a series of protein bridges that form. And the pattern of the protein bridges tells it either activates the immune system cell, and the immune system cell is able to recognize that it's cancer and do something about it, or it shuts it off. And the reason that mechanism exists is to protect our healthy cells, because your immune system cells, they're really smart, but they bounce into every cell and have to decide if they're going to kill it or not. And if we didn't have those checks and balances, we'd get way more autoimmune. And so what Keytruda or pembrolizumab is doing is actually severing it's blocking one of those protein interactions that would normally turn off the immune system. So now the white blood cell can be very strong and activated and can kill it. But we are more at risk for autoimmune, inflammatory reactions related to them. So with an intratumoral approach, you can deliver a lower dose right to the source.
Right.
Usually
without usually having that effect on the entire immune system.
Yeah, right? Yeah, without having as many systemic, and you can inject more than one, and there's more wiggle room. Usually it works best if it's paired with an ablative technique like a cryotherapy or a like a pulsed electric field, PEF frequencies. But again, that might be limited in the pancreas because of the location of it. So,
but if you're doing something like that with maybe a low dose chemo potentially, plus some of these other therapies, that, and I'm thinking of one of our patients just left to go home not too long ago. He did great with that approach. Now again, he did great and he's doing really, really well. Then it's just a matter of surveillance and monitoring and things like that. But he came pretty banged up, honestly, and he went home doing really well with all of those therapies that we just talked about: the low dose chemo, the intratumoral injections with the immunotherapy.
And we referred out for that, just to clarify.
Yeah, for
that's
clarity,
not done here.
Low dose we did here, we referred out, but that's the affiliations that Dr. Ptak was talking about, that we have these affiliations that if we know something's working, and I think this is a huge positive for us in the sense that we know sometimes these other modalities are going to be necessary, and we have these affiliations now that we could send to, whether it's sometimes a more targeted hyperthermia, right? Or again, intratumoral immunotherapy injections, or whatever it might be. We can now do that and then be a guide for the patient that not only they get work done here, but we know they're going to get all this help elsewhere too. And at the end of the day, it's all about results. So it's a good thing. So yes, there are some more things with pancreatic cancer that we can do that seem to be very helpful, and they're learning more things every day. So it's good. Okay, immunotherapy in treating melanoma, and how has it transformed the prognosis for patients with advanced skin cancer?
So I feel like I partly answered that a little bit by talking about Keytruda. Melanoma for, I guess, various reasons, but tends to express a lot more of that PD-1,
Right.
that thing that Keytruda intervenes with. And so risk of recurrence for kind of early moderate stage melanomas is lower if after the wide local excision Keytruda is applied, depending on other parts of the pathology, how deep was it invading and what type of histology did it have. Was it wide, was it superficial spreading or nodular, or there's different types of presentations of it. And then as far as how has it transformed the prognosis, I mean, there are several patients. I'm actually thinking of one story that the Dr. Williams was telling us about, the melanoma patient. It was stage 4 melanoma with multiple lesions in the lung, and it was kind of a last-ditch effort. He did the intratumoral immunotherapy to just one of the spots, and because the immune system was so activated, all of the spots disappeared. And we'd love for that to happen every time. It's not always that miraculous, but that just goes to show this person was left basically to go home and be with family, and then boom,
cleaned up.
So it's certainly transformed, and there's a lot of options, and they're always coming out with more immunotherapies. I'd say the limitation currently is how expensive it is for the research and development of these drugs. To bring them to market costs, I think, billions of dollars.
Right.
And so they end up being very expensive when they hit the market, and there's a lot of limitations to what kinds of cancer and what stage and how many lines of treatment you may have had to have failed before you become eligible through your insurance. So that's certainly a limitation. But I'm happier, I'd rather we have them and still be working on developing more than not have them.
Yeah.
Just despite their cost. So.
For sure. Agree. All right, so this is one we get all the time. What would you say is the most common cancer-causing agent? Stress, genetics?
So that's the one I brought back up to the top. So.
Yep. Yeah, we talked about the causes, reiterated. Yeah, I mean, stress, when you look at everything that stress does to the body,
cortisol is a steroid. It suppresses your immune system
significantly, and then there's certain hormones that are shut off or turned on because of stress that have a cancer protective mechanism.
And when you're stressed, you breathe more shallowly and you're not as oxygenated.
Yeah, I think stress, emotional, physical, or chemical, which they're the three categories, if you will, of stress. is probably up there at the very high.
Because it just sets off the cascades of issues. And one of the questions there's two questions we always ask patients. One, what was your stress like 5 to 10 years ago? Because that's the timeline we see that significant stressor setting off, a slow march towards a diagnosis. And it doesn't mean that we shouldn't experience stress. There's a hormetic effect, meaning a little bit of stress calls you to action, and the physiology that your body amounts to calm a stress response ends up having a rebound anti-inflammatory and calming effect, but the stress has to come down. It means you have a stressor and then you rest.
Yep.
And
it's the fight or flight versus rest and digest. There's a equilibrium, if you are homeostasis, that it goes up. It's designed for something. It's burned off. It comes down. We're back to equilibrium. It's when that's up constantly and to a high level, that's when the detriment happens, and for a prolonged period of time.
Yeah, I'm thinking about, do you actually, when you compare how humans respond to stress compared to animals, something you see, I'm picturing, I saw a video, they were talking about heart rate variability and stress. I wasn't watching like a crazy animal video on YouTube, but there was a polar bear that was being tracked by poachers, and it was being chased, and it had sustained an injury before law enforcement came to protect the polar bear. And the polar bear kind of laid down and started like running while it was laying down, just to like discharge the energy, and then it got up and it was fine. And I think about how humans respond to stress, and we get frightened, or we think about something at work, like some ongoing issue at work, and we just our shoulders creep up, and we're sitting there and we hold it in, and we're suppressing it, and we're ignoring it. So you have to honor and process and rest and find peace, however that looks for you. And the second question I always ask patients is, how many minutes a day do you spend doing something totally peaceful? And it doesn't mean being on your phone or even listening to music. Like, we don't always listen to the most relaxing music in our day and age. Classical is not very popular these days. But how much of your day do you spend praying or just sitting there, mindfulness and in gratitude? And the number of people I get looking at me like, I've never even thought about, like, I don't even, zero minutes. It's like, okay, guys, we all gotta collectively
slow down a little bit, right? Take that time, and it's not easy, right? It's I personally I need the exercise. I need to burn off that stress. So when you exercise,
so you're the polar bear.
I'm the polar bear. You mimic when you have fight or flight and stress. You're basically producing certain hormones and certain biochemistry that is designed to allow you to run like heck or fight like heck. Well, if that's on all day long, that chemistry becomes very detrimental, to keep it simple. So high intensity, short burst exercise mimics, if I had to fight or run like heck, you do that and you burn it off and you're back to equilibrium. So it's a big, that plus meditation, plus mindfulness, plus prayer, anything like that is going to help significantly offset the chemistry that's produced by stress. Especially if you're in an environment, a stressful environment consistently, that should be part of your day, is trying to figure out how to burn some of that off, or kind of calm your brain down to peacefully exist with that stress. And then support, not to get too into the stress talk, but then support, there's adaptogens that really help the area of the brain that regulates certain hormones called the HP axis, not to get too nerdy. But then you get your ashwagandhas and your cordyceps and your ginsengs and your maca roots and things like that are really good to help the brain facilitate or keep your stress hormones in check, if you will. So there are strategies, and if you're experiencing those, get with us, because we can easily kind of guide you through that for sure. Okay, so we'll take one more.
Okay.
Yeah, and then we will answer these and get back to you, I know. Okay, so hyperbaric and stage 4 colon cancer. I understand that cancer thrives in low oxygen environment, but I also worry that the oxygenation of your system, you're going to spread the cancer. So basically they're asking if hey, I have cancer and I oxygenate, that they read it could spread the cancer. Can you explain further and how you determine if hyperbaric is good for a particular patient? So go ahead, I have my own thoughts on that.
Yeah, so I think in my understanding of the research, hyperbaric is going to behave very differently in a cancer tissue and a non-cancer tissue because the overall physiology is different.
Sure.
When we think about cancer, we're thinking of hypoxia-inducible factor, which means low oxygen everything. That's driving a very dysfunctional physiology forward.
Yep.
Oxygen in that area doesn't increase vascular growth or the other negatives that we would associate with the benefits we typically see for hyperbaric in a healthy tissue.
Mm-hmm.
So there's definitely research on this, how hyperbaric and increased oxygenation in a cancer tissue behaves differently than in a healthy tissue. So I invite everyone to look into the research on that. There's a couple choice papers. Maybe we can send out the citations and the follow-up email to this. I'd be
but
happy
it's all
to.
favorable
It's
to
all,
utilizing
yes.
hyperbaric or oxygen
Yeah.
in those cancer cells. It's all favorable from what I understand.
It's radiation sensitizing, it's chemosensitizing. You have to be careful with a couple different chemotherapies under greater atmospheric pressure. That's what hyperbaric is, that it increases the atmospheric pressure on you.
Right.
That might affect how the drug is metabolized, making it processed faster or slower. But that's a lot less frequent of an issue than people make it out to be.
And that's the clinician is, if you're on some of those, can determine best approach.
Yeah, the main ones that we are careful with are doxorubicin or adriamycin and bleomycin. And then maybe some of the platins, but it's case by case.
So that would include not just hyperbaric, but if they were doing CVAC or they were even doing ozonation or ozone. Ozone is, from what I understand too, nothing but beneficial from a standpoint of helping reestablish the terrain that's needed for healthy cells, right? Would you agree? Okay. Yeah, so hyperbaric is one of the oxygen, producing modalities that we use, but it's, from what we understand, all favorable. Okay. So, okay. All right. So because we're running out of time, we'll stop there. We'll definitely pick these questions up. We'll pick these questions up. So every other, I guess once a month, I should say, we're going to do a Q&A session. So save your questions. We'll get to these if we can, and then we will continue to. We have a lot of them there, about 51 of them. So we will continue to use these, and just every month we'll do a Q&A, and we'll start with these first and put these on the next Q&A. And maybe Dr. Ptak and myself, if she's with me, we'll go through a little bit faster. I know I'm a little chatty for sure, so you're good. You do a good job. So anyway, we'll try to get through them a little faster, but some of these do require a good valued explanation. So, but anyway, we're going to do this every once a month, so we'll get to as many as we can. I just want to touch on this for y'all. Personalized patient plan, and I did want to mention early detection for heart disease, cancer, diabetes, autoimmune. I mean, whatever somebody would be worried about as far as getting. This is all about getting the right testing done, including blood work, including live blood cell analysis, some of the energy testing that we utilize here at the clinic, and trying to get a better idea of some of the things that could be going on in the body, right? Because even though you express health and maybe you don't have symptoms, it really doesn't mean in today's world or environment that you're clean. And so if we start looking, we'll probably find, right? But that's not a bad thing. That means that we could start cleaning up some of those fuels to the fire and make sure that there's less inflammation in the body, your immune system's much better regulated and stronger, and then you're creating an environment that's very conducive for anti-cancer, anti-disease, longevity. I've mentioned this a bunch of times. I'm getting into the whole hot and cold therapy, so cold plunging and the saunas, and then what that does to the different proteins that protect us, the adversity genes they call it, and then what fasting does, and then just trying to create an environment that is a little bit more adverse, right? Hot, cold, fasting. Some of the theories are that we just don't go through that in our daily life anymore because we're so comfortable. So make yourself uncomfortable is kind of the adage. And that does help protect your cells. So we can get into all that. And even in the new cancer conversation, I really want to go down that road and teach what I've learned, because I think it's fascinating what they're talking about in the cellular health, and even trace minerals at the cellular level, and how to use Quinton water right, and all these different things that I think are fascinating that I think get into the cellular health as well. But this is, if you're looking for prevention, this is the plan that you would call and ask for, and then Miles would get you scheduled, and we would pre-schedule all these things before you came in. So really good plan. I think they did a great job of putting it together. The packages, a couple day package could be somewhere in the $2,500 to $3,000 range, but it includes everything that you see on here, which is a significant overall savings. So good if you're looking for that package deal. That doesn't mean you can't call and come in and have a consult, get your blood work done, and kind of take it step by step. You can absolutely do that. This is just for the people that call and say, I want the full deal. Okay? So I hope that's clear. So you can read that. And then just to close, we always get questions the next day. So I want to go over, if you have active cancer, friend, family member, anybody that wants to learn more, 949-581-4673. And the cancercenterforhealing.com is the website. Hyperbaric oxygen, 949-680-1904. We mentioned that, so I figured we'd put that in there. The Perfectly Healthy Store, we didn't talk too much about the supplements, but 866-616-7474 and perfectlyhealthy.com. And then for the center side, if you did want to schedule a consult or schedule a package deal, then 949-680-1880 and cfnmedicine.com. Okay? So thank you for joining us, Dr. Ptak. Thank you very much for coming on tonight. I appreciate it. And I want to take the time to let you know, hey, keep working hard, keep striving for information, because it's coming out really at a feverish pace. Yeah. So we're keeping up. Like once you get into this world, Dr. Ptak will tell you, it's like opening a can of worms. You're never done. So you're always going, which creates some stress. So
I'm feeling really peaceful right now.
Yeah, that's good. That's good. Now she's probably going to go work out for, would you say, like 3 hours, your trainer? No. Okay, anyway. All right. So, okay, gang, have a great couple weeks, and we'll see you soon.
Night.
Bye-bye.